Thank you for inviting me to this webinar. I would be spending some time trying to explain how NAFLD we can integrate with the ongoing program, the flagship program of NCDs, what is known as NPCDCS. We had a humble beginning in 1975 when we started addressing some of the NCD challenges in the country, piloting it in 10 districts in 2008 and increasing to about 100 districts in 21 states in 2010. And with the arrival of about NHM by 2013-14, we had rolled out in 36 states and UTs. By 2015-16, we covered about 468 districts. And 2018, there was a paradigm shift when we started thinking about comprehensive primary healthcare packages through the health and wellness centers. And we also started doing the population-based screening of NCDs. And 2020-21, we had a new edition of NAFLD into NPCDCS. This is in brief. I am trying to explain the journey from 1975 to 2021. So the main objectives of the NCD program is health promotion through behavior change, and then population base, which I had already explained how we had introduced, and also the ongoing opportunistic screening. In the sense, the population base will happen at the doorstep, but if somebody happens to drop in any of the health facilities, the opportunity screening of the NCDs also continues, and prevention and control of chronic NCDs, capacity building in terms of training for various components of the NPCDCS program, and we also support the diagnostic and the cost-effective treatment at all levels of healthcare. So in brief, with starting of NPCDCS from 1975 till now, we have got 4,807 CHC NCD clinics, and we also have at the district what is known as the district daycare centers for oncology, for the palliative therapy, and the cardiac care units again at the district hospital in 190 of them, and the district NCD clinics are in about 643 districts. And the administrative unit at the districts, we have covered about 678, and we have the state NCD cell in all the states of this country. So the population-based screening, let me spend some time here. This is one of the package of the comprehensive primary health care, what is known as CPC in 2018, and we are targeting about to all those people who are at 30 years of age in the community for the common NCD. Say the ASHA will come to your doorstep, she will enumerate the members who are staying in the population, and for NCD purposes, she will screen through a form which is in a paper form or in a digital form through an app in her mobile phone or the tablet, where the community-based assessment checklist will be applied to those individuals above 30 years of age. So by that, the screening for the risk factors as well as the common NCDs are being done. And this is being implemented in about 480 districts. And the case is trying to help in the better management of diseases by way of early detection, follow-up, and then treatment adherence, etc. So it also, by the mere fact of somebody coming to your doorstep and asking whether you smoke, whether you consume tobacco, or whether you use use alcohol, or do you have any family history of diseases like hypertension or diabetes, that itself is generating a lot of awareness about the risk factors and the NCDs as such. So the non-alcoholic fatty liver disease, in a way, with the ongoing program, it has come as a surprise to us. But when we started interacting with the ILPS team, we realized that NAFLD is the core of many of our ongoing NCD programs. Say, if you have a fatty liver, you have a risk for diabetes and vascular complications. You have the risk for future stroke, hypertension, and atherosclerosis. You have risk for CKDs and the polycystic ovarian disease, and also main diseases of the liver like fatty liver disease, gallstones, and also hepatocellular carcinoma. So if you really take care of NAFLD and the precursors like the fatty liver, we are going to take care of many of the NCDs in future. So that is why when NAFLD was introduced to us, then we felt that if we really take care of NAFLD, we are going to take care of many things, and we are not going to anything drastic or anything very new, anything which is going to change the whole system or a new approach, but it is only tweaking of what is already happening with NPCDCS and trying to address the NAFLD issues for the benefit of NCDs in future. We all know that NCD is a huge burden by itself, and NAFLD has a prevalence about 30%, more than 30% of the general population, and 2/3 of the diabetes are going to have NAFLD. So the risk factors, if you try to see the NCD risk factors, the cardiovascular diseases and the NAFLD, many of them are common, and if you map them together, many of them would be similar. Say, for example, if you take care of the physical inactivity, it is going to take care of many of the risk factors of NAFLD. If you take care of metabolic syndrome, hypercholesterolemia, obesity, diabetes type 2, you are going to take care of NAFLD. Rather, if you take care of many of the risk factors of NAFLD, this will have a similar effect on the risk factors in terms of the outcome of the NCD. So we really mapped out the risk factors of both NCDs and NAFLD, and then we realized that it is very, very doable. So for that matter, the ministry has drafted the operational guidelines, which was finalized with the ministry, NSSRC, the DCSS team here, then ILBS and our partners like WHO and UNDP. And then we are having a lot of sensitization workshop with the state and the district nodal officers, medical colleges, nursing fraternity, members of professional bodies of public health, etc. And we also got IEC support from the various development partners. And we are also in the process of doing a gap analysis. If at all, if we want to integrate NAFLD in a district hospital, we have to see what's the facilities available there, the manpower available, the diagnostic facilities, the equipments available, the treatment facilities available there. And if you aim to build on for NAFLD facility, what is that gap? What are the things which is listed for NAFLD, which you need to put on that into the district hospital so that we have the facility for NAFLD. So the launch was done by none other than the Dynamic Health Minister, who launched the operational guidelines for integration. And he had also instructed all of us that rather than just the book, we should be working on various components, the training component as well as the IEC component, as well as the gap analysis component, so that we have in place NAFLD integrated with NPCDCS. So we are proud to announce here that India is perhaps the first country in the world to identify the need for action of NAFLD into an existing health program. So the implementation strategies, if you remember what I said for NCD, we will try to do it here again for NAFLD. Health promotion is common, awareness generation, promotion of healthy lifestyle is all common. Screening and early detection, we were already doing with PVS. We are also trying to tweak a little bit so that we detect NAFLD for NAFLD as well. The timely and affordable accurate diagnosis, we are already doing in many of the NCDs at the level of health and welfare centers or the PAC, or at least in the NCD clinics at the CAC or district hospital, and access to affordable treatment with other NCDs as well. This is also one of the components. And rehabilitation, now we'll have to tweak a little bit more for NAFLD. This is what strategies we thought we would do. And if you want to do health promotion and prevention activities, then we have to plan it to raise the awareness at each level of the healthcare. We have to talk, we have to discuss, we have to plan, and we have to involve everybody in the health care delivery system so that they know what NAFLD is. And in terms of the mass messages, we have to do mass and the media and the social media to promote the key messages for NAFLD on various occasions, like the World Liver Day or any other day which is celebrated or observed for any of the NCDs. Then international and the national days can be celebrated, and then we can tweak around liver. Then we also have lots of meetings and sensitization workshop like what we are doing today, conducted at various levels, and we are also trying to promote key messages at the ANM and medical. So the ASHA and the ANM who have been now trained for population-based screening, if you give them little furthermore training, then they'll also understand the importance of liver and the importance of detecting and preventing NAFLD along with the NCT. So we are not going to burden too much on the ASHA, but we just have to inform that when you are doing, when you are asking the height, weight, and the waist circumference, and also say pedal edema, you are doing it for some other purpose. If you do it now, it has got some bearing on NAFLD. So it is like tweaking what she has already been doing and making her realize that she was already doing something for NAFLD. And community level awareness, I was already telling you about the ASHA, and some more proposed activities can be abdominal obesity. Then we ask for the history of diabetes, hypertension, coronary heart disease. We have been already doing it. We may increase to ask the history for liver disease, gallstones, etc. And cancer, we were already doing it. So it is like putting 2-3 more small key activities on the activities which is already being done by ASHA to increase it to fulfill the needs for NAFLD. Then the sub-center activities, I have already told you what is existing in NPCDCS. We will now train the ANM to do little bit about calculating the BMI and confirming the pedal edema which was detected by the ASHA, etc. And then put on the referral chain to the medical officer at the PAC, where the diagnosis and management of common NCDs either through the population-based screening or directly coming into it. And this inclusion of NAFLD can happen here when the medical officer examines it, if his capacity is built. And then the referral chain continues. And at the CAC, some of the diagnostics which are already there for PBS, for the NCDs can be put into it, and then we can tweak the available investigation diagnostic facility to fit the requirements of the NAFLD, like the fibrosis 4, the FIF4 score, which is just trying to understand the different parameters according to a well-designed score for the purpose of diagnosing NAFLD. Can happen here in CAC if you really want to do it here in any of the CACs. It is possible. And the referral chain continues at the district hospital. We need little more concrete management level here, management of the NAFLD which has been referred. Then we can do a risk stratification for advanced liver fibrosis. If that was not there, if that facility wasn't there in CAC, we can do it here now. And for patient with the indeterminate risk of for advanced liver fibrosis, we can do what is known as the ELF test for the fibroscan. So many of the district hospitals in the country, if the capacity is built in such a way that they have a fibroscan, then we can have this risk determination. And we also know that many of the district hospitals now are being converted to medical colleges. So the medical colleges also comes into the picture where they can be built, the capacity of which can be built to do this. And at the district hospital, we can have capacity training activities for the MOs as well. And then if the diagnosis is very advanced and if we think that the facility at the district hospital is not adequate, then we further put on the patient to the referral chain to the tertiary care hospital. Then at the medical colleges and the central government institutes like AIMS, all across the country, the risk stratification can happen here. Then the patient with requirements for fibroscan can work here. The diagnosis and management can be done by the various departments of medicine or gastroenterology, wherever is available. So now, in order to help the government with this, we are also thinking of, providing a national center of excellence, where one institute of the country can be entrusted with developing guidelines for training, guidelines for IEC, and also monitoring and evaluating the NAFLD component of the program. And in future, once the National Center of Excellence is there, if the program grows more, then we can also think of the State Cancer of Excellence in each state. If not the State Cancer of Excellence, we can combine 3-4 states together and have a regional center of excellence. And to give you a little bit of idea that health is not going to be NCD is not going to be just a health sector program. We have what is known as the National Multi-Sectoral Action Plan, where health is now being seen as a key factor for the country's fulfillment of the Sustainable Development Goal. Hence, it needs to be worked out by many areas with many different ministries and partners, and we do this through the NMAP, what is known as National Multi-Sectoral Action Plan. We also have generic promotive activities in the form of Fit India, through which the NCD team here in the ministry was part of the Fit India Appropriate Fitness Protocols, which we developed with the Ministry of Youth Affairs and Sports in the age group 5 to 18, 18 to 65, and 65 plus age. Then we also have what is called as the Eat Right campaign with the FASAI of Ministry of Health and Family Welfare. And to briefly tell you what's the way forward, we are trying to prioritize through media plan, then inclusion of OG, the operational guidelines in the main NPCDCS, and also we have to include what is called as the financial management for FMR codes in the program implementation plan, and monitor it and ensure that whatever we have written in the operational guidelines is available at the various levels of healthcare. So this is all in brief. I wanted to share how we plan to integrate NAFLD into NPCDCS.